we have this new liver disease epidemic that has emerged over the last decade, which is called non-alcoholic fatty liver disease, which is closely linked to the problem of obesity. Now, throughout the world, everybody knows the link between obesity and heart disease, obesity and type 2 diabetes, but this is sort of the new kid on the block when you think about how obesity affects the entire body. And if you look at the liver under the microscope, there are two broad phenotypes. One where you get fat, not much else, that's a fatty liver. And then you have the lesion of steatohepatitis, which is a very specific histological entity where in addition to the fat, you get a lesion called ballooning and inflammation, and steatohepatitis is more likely to be progressive. So why is this important? Well, it is not only important as a cause of cirrhosis, it is also, can we turn the sound down a little bit? There's a really strong echo where I'm standing. Thank you. It is not only important as a cause of cirrhosis, but this condition is really driving the national increase in liver cancer. Now, these are data from the MMWR that were just published last October, last couple of months ago. And it looks at various obesity-associated cancers. And you can see colorectal cancers going down, breast and all-cause obesity cancers relatively flat. But for the last 10 years, the risk of liver cancer has been, not the risk, the actual incidence of liver cancer, not even the prevalence, the incidence of liver cancer has been increasing at 3% per year. So what will happen if you don't do anything? So we modeled this, and this was just recently published, and it shows that the number of people with cirrhosis will triple. All of us who take care of liver disease know that once you get cirrhosis, the burden on the patient and the cost of care goes up exponentially. And over 300,000 people will have what we consider cirrhosis with liver failure or end-stage liver disease. And of course, particularly frightening is that many of these people will actually be today's children, because 10% of our children have this disease. So frightening statistics if we do nothing as this disease marches on through the next 2 decades. So my title was to make the case for combination therapies. How do we get there globally? So before we get caught up in therapies, and particularly combination therapies, it is important to keep perspective on this disease, because this is the ultimate case of food poisoning. When you drive excess food into the liver has to figure out what to do with it. So there's metabolic substrate, which is carbohydrate and fat, that is being poured into the liver. So while you're having fun eating, your liver's actually quite miserable. So keeping that in perspective, let me show you how this translates into the liver disease. So if you start at the top over here and look at dietary fat, and on the other hand, you look at dietary sugars and amino acids. Dietary fat can either go to adipose tissue or directly to the liver. Adipose tissue release of fat to the liver is mediated by insulin sensitivity. So once you become insulin resistant, you get more lipolysis. And if you have increased gluconeogenic drive, you can convert amino acids into acetyl-CoA, which is the backbone for fat synthesis, or you can convert sugars into lipids, and together they contribute to the free fatty acid load to the liver. Now, once you increase free fatty acid load to the liver can either oxidize it, or it can store it as a safe neutral lipid, which is triglyceride, which is what we see under the microscope. But at the same time, these excess free fatty acids are very, very toxic. And they produce hepatocellular injury by affecting just about every cellular function that we have. And that induces either repair or inflammation. And together, this leads to the phenotype we recognize as NASH It can lead to progressive scarring of the liver and even liver cancer. There are, of course, systemic factors that can modulate this process as well. So this, of course, gives us a roadmap as to where we should target this disease cascade in order to have the best effect for therapeutics. So that leads us to two concepts. The first concept is one of disease activity, and the other is that of disease stage. So if you imagine a normal liver that starts developing metabolic substrate poisoning, it starts undergoing that process that I just described towards cirrhosis. Disease activity is a term that captures all of the processes that are injuring the liver and driving the disease towards cirrhosis. Disease stage, on the other hand, tells us how far you've actually traveled, how far the liver has progressed to cirrhosis. Imagine you're driving from point A to point B. Disease activity is the number of RPMs on the machine. It tells you how hard the engine is working. And disease stage is the odometer, which tells you how many miles you've actually traveled. And of course, disease activity is recognized by the lesion of steatohepatitis as opposed to fatty liver, or by various activity scores. On the other hand, disease stage is recognized by fibrosis. And of course, once you get to cirrhosis, that's what leads to liver-related outcomes. And so progression to cirrhosis and preventing progression to cirrhosis is really the key goal of therapeutics when we talk about pre-cirrhotic stages of the disease. And in fact, the progression to cirrhosis is now considered a generally accepted surrogate endpoint for full approval of drugs. So at a molecular level, in terms of targeting the disease activity is assessed from this metabolic overload, markers, cell stress, inflammation. And we know that these three things, the activity, actually drives the fibrogenic response. So activity drives stage, and stage is a marker of disease progression, and therefore the stage is related to clinical outcomes. Disease activity is more further removed, and so is not as strongly associated with clinical outcomes. So looking at it yet another way, if you start with a certain certain predisposition, if you have a certain genetic background, based on your genetic background, you have a certain predisposition towards getting the disease. It doesn't mean you'll get the disease. It tells you that if you stress your system metabolically, you're more likely to get the disease. And then typically the disease initiator is when you start pouring in excess metabolic substrate, and that leads to two kinds of activities. So expanding further on those downstream changes from the lipotoxic stress, you essentially get pathways that perpetuate the disease and lead to progressive inflammation and fibrosis. But at the same time, the liver has an incredible healing property. So you activate stem cells, there's increased regeneration, there's cell matrix crosstalk, changes in microcirculation, and extensive metabolic reprogramming that tend to restore tissue architecture and tissue function. And it's the balance between factors that are driving the disease forward versus the factors that are trying to heal the disease that determine your phenotype and whether you will progress, remain relatively stable, or actually spontaneously regress. And all three phenotypes have been described, and the underlying mechanism is this balance, which is very dynamic. Even in an individual, it changes from time to time. So we have to understand the biology of the disease before we jump in to try to tackle this condition. So given this complexity, it is really important to understand at a molecular level the pathways that are driving disease activity versus disease fibrosis. So this is an analysis that we've just very recently completed based on a cohort of about 100 patients covering the entire spectrum of fatty liver disease, from fatty liver with no fibrosis to cirrhosis, the whole spectrum. High activity, low activity. So this is a little bit of a complex slide, so I'm going to walk you through it step by step. So first of all, we look at gene expression and relate it to the probability of it being activated to disease activity as measured by the NAFLD activity score, as shown in the blue bars over here. So this is the blue scale that shows how likely it is to be associated with NAFLD activity. The orange scale over here tells us how likely it is to be associated with fibrosis. And of course, the heat map in these big bars tell us the fold change compared to control groups. And we look at this by developing something called an exclusivity index that we've developed, which looks at the probability of any gene or pathway to be associated with either the disease activity or disease stage versus the probability of not being associated with the other factors. So if you're looking at disease fibrosis, it would be the probability of not being associated with disease activity. If you're looking at disease activity, it's probability of being related to disease activity times the probability of not being associated with fibrosis. So when you look at this, this gives us a heat map of differentially expressed genes. And what is very important that pops up over here is that for disease activity over here, associated over here in blue, as well as for factors that are particularly associated with fibrosis over here, and this is highly significant. You see how dark red these are. Again, inflammation pops out as a major driver. So what connects the metabolic stress to the fibrogenic remodeling of the liver is inflammation. No surprise, but now we have actual real data to show this. And in fact, this is corroborated by looking at inflammasome expression, and these are data that we've just came out 2 weeks ago, and actually correlate pretty tightly also with data from animal models of NASH. These are data from our diamond model showing toll-like receptor activation. So the innate immune system activation and the inflammatory pathway activation are really critical to disease progression as you move from fatty liver towards steatohepatitis and fibrosis. You can also perform network analysis, and this reveals actually a very strong signature of not just extracellular matrix related pathways and genes, but also of oxidative stress, cell regeneration, and metabolic reprogramming with TCA cycle related genes that are differentially activated and are very strongly related and have super additive effects when you look at their effect on disease activity versus disease stage. So this gives us, from this complexity, we can boil it back down to a more simple paradigm where you start with a metabolic stress to the liver, which is insulin resistance and delivery of excess fat and carbohydrate to the liver. This produces cell stress because the cell metabolic machinery has to go into overtime to deal with it, gets very stressed, has no time off, and so if you work it hard enough, it dies. If it doesn't die, it leads to inflammation and cell regeneration, and eventually fibrogenic remodeling and cirrhosis. This also forms the basis for our thinking for therapeutics, where we can hit the drug either at the front end or at different points along this pathophysiological cascade. Of course, the outcome will depend on where you hit this disease cascade. So logically, if you hit it at the front end, everything else eventually should cool down. But we know that once your disease has progressed past a certain point, the inflammatory and fibrogenic signaling develops a life of its own. It has its own internal perpetuating mechanisms. So you may need more than one type of disease mechanism. And that is the fundamental basis for thinking why we need combination therapeutics. In fact, if you look at just targeting one target, we've looked at a number of now phase 2b trials. These are data with vitamin E and pioglitazone from the Pivens trial. This is from the obeticholic acid from the Lancet paper. And they're all highly significant compared to placebo. But if you look at this, only about 40–45% response rate for any of these drugs. So is it because the rest of the patients were not taking their drug? No, that's not true. We've looked. It's not a matter of compliance. So despite having adequate drug levels, why is it that only 40–45% of people are responders? And we think that's because there is molecular heterogeneity of the disease. So we really need to understand the degree of heterogeneity within this disease spectrum. A very simple example of this is that as you progress to cirrhosis, initially disease activity increases, but once you get to bridging fibrosis and progress into cirrhosis, disease activity starts burning out. And there you just have, as I said, fibrogenesis develops a life of its own at that point. This is shown in this study where we took precision-cut liver biopsies and exposed them to labeled acetate and palmitate and looked at its incorporation. You see a big jump in triglyceride synthesis and in cholesterol synthesis with fatty liver and NASH. And once you get to cirrhosis, this starts going back down. In fact, this may be one of the earliest signs of functional failure of the liver as you progress into cirrhosis. And this is also the reason why your lipid profile improves when you progress into cirrhosis. The triglycerides, the cholesterol, everything gets better when you develop cirrhosis. Of course, it's not a good thing at that point because it reflects you're really, really sick. Now, animal models have now been refined to the point where that we have now validated them to very closely mimic many aspects of human disease. And they have now allowed us to longitudinally study the models to give us a longitudinal molecular model of disease development. And what that has taught us is that different genes are turned on at different points in time as the disease develops and progresses. So it is not monomorphic. A disease target may be relevant in the early phases, mid phases, or late phases, or throughout. It all depends on the pathway that you are targeting. So if you look at fatty liver, PPAR signaling is very active early on, but inflammation is relatively low but progresses progressively. Proliferative and oncogenic signaling increases late. So this allows us to develop differential approaches to where somebody is. So theoretically, you could imagine for an individual patient, if you knew exactly where they were, you would know which pathways are most relevant for that particular patient, so you could target them appropriately with the right drugs for that patient. So what we traditionally do is we take all patients who have one histologic phenotype, we throw the drug at them and hope for the best. But I think the smarter way to do it, ultimately in the long term, will be to know exactly what the drivers of the disease in a given patient are, and then match those drivers to the patient. And this has already been shown. This is human data showing that there are metabolic signatures in the circulation that can allow us to distinguish what pathways are changing as the disease evolves from normal to fatty liver to NASH. So this now sets us up to match the right patient to the right drugs. So if you bring us back to this concept of disease activity versus disease stage, understanding that disease activity ultimately drives disease stage or fibrogenesis, you can divide this plot into 4 quadrants. In the lower left quadrant, which I call the green quadrant, you have low activity and low stage. So this is your typical patient who just has maybe fatty liver with a smattering of little inflammation. This person's likelihood of dying from liver disease is very, very low. You don't want to really use drug therapy for this person. So lifestyle, etc., for this person. On the other hand, if you have high activity, you know you're at risk for progression. You may want to target front-end acting drugs, because if you tackle the front end of the pathophysiologic cascade, the downstream parts will eventually cool down. And if they have very little fibrosis, you got lots of time. This patient is in no imminent danger of dying from liver disease. On the other hand, if you have advanced fibrosis, bridging fibrosis, and you have a severely inflamed liver, that person is at particular risk of progressing into cirrhosis. There is the classic patient where taking a front-end acting drug and a downstream acting drug makes most sense. And then, of course, if you have burnt out fibrotic liver where there's not much disease activity, you primarily need an antifibrotic approach. Going even one step further, and this is purely conjectural, you could imagine that you could categorize patients based on things that are turned on. So satiety mechanisms, impaired thermogenesis, blah, just a laundry list of potential pathways and things that could be affected. And different patients may have different patterns. That could be from low to high over here, shown as a heat map. But this could tell us how to target individual patient for therapeutics. There's already data. We're using network analysis showing that which pathways are particularly linked to vitamin E responsiveness. So if we know, for example, that lipoxygenase 5 is involved, 5 heat, if it is increased, could be a biomarker that you're going to respond to vitamin E, for example. So this is just a potential example. In fact, we did this in the PIVENS trial for vitamin E, and we have a list of biomarkers which tells us that whether a person is going to respond or not going to respond to vitamin E therapy even before you start therapeutics. So this allows us to move forward towards more precision medicine-based approaches towards actually identifying who will respond to which. So this allows us to then find out which targets or combinations of drugs would make sense in a given patient. So when we think about combination therapy, ultimately this is the poster child for precision medicine, where we can identify based on transcriptomics from a liver biopsy or lipidomics from blood draws, which pathways are turned on in a given patient and are likely to be disease drivers, and therefore which combination of targets would make the most sense, and thus which drugs are most likely to be effective. Another way of thinking about combination therapy is to target multiple organs simultaneously. So you're combining your therapeutic targets not just at a molecular level, but actually at the organ level. So you're treating more than just the liver. Remember that your average diabetic patient now is getting 3 drugs for they're getting metformin, they're getting insulin, they're getting a GLP-1, they may get a SGLT2, 3 to 4 drugs for their diabetes. They're getting 1 statin, they're getting a fibrate, they're getting a another something for their HDL. So they're on 2-3 drugs, then they're on aspirin. Then they have to take PPIs because all of these drugs are giving them heartburn. Then you gotta give them something for their anxiety because taking all these pills is making them anxious and anorexic, nauseated all day long. Then you have to take something for the nausea and so on. So the list continues to grow. So our average patient is already taking 10, 12 drugs. So you may want to consolidate, as you think of drug development, how you integrate your therapeutic approach. And so can you really improve multiple end organs simultaneously? And I think that's the future. And because it's, I think, feasible. If you look at the pathophysiology of beta cell failure, so this is not my work, this is not anybody in hepatology field's work, this is work that comes out of diabetes. Increased free fatty acid flux leads to abnormal lipids such as ceramides, triglycerides, leads to endoplasmic reticulum stress, impaired autophagy, mitochondrial dysfunction, oxidative stress, beta cell dysfunction, apoptosis, ultimately fibrotic replacement of the beta cell. Well, doesn't that sound awfully familiar? If you replace beta cell with hepatocyte and type 2 diabetes with NASH, I just described the pathogenesis of NASH to you. So you have an identical collinear biology going on in multiple organs at the same time. Another very important organ, just north of the diaphragm, where we rarely look as hepatologists, is the heart. So if you think of this disease as a disease of ectopic fat, inflammation, and fibrosis, as we progress from fatty liver, NASH to cirrhosis, there's increased atherogenic risk factors, subclinical disease, actual atherosclerosis and narrowing of the arteries, some cardiac events, and ultimately scarred up heart, just like a scarred up liver, which has heart failure with preserved ejection fraction, which is the most common form of heart failure, which, by the way, the cardiologists are clueless about what causes this. So we're going to have to help them out. So if you look at the data, you can see that if you have NASH, with increased ALT, there's more atherogenic dyslipidemia, and the higher your ALT, the worse it is. And even with very small increase in ALT, if you're within the normal range, but above the 19 and 30 thresholds for normal ALT, you have an increase in dyslipidemia. And similarly, when you actually look at the biopsy and you go from lean to obese controls to fatty liver to NASH, there's worsening dyslipidemia and particle size. Whether you have lean NASH or obese NASH, the proportion of people who have the mean LDL particle size is smaller, which means it's more atherogenic, it can penetrate the endothelium more easily, it can be more easily oxidized. If you go all the way to clinical events, you see from the NHANES data, this is Ray Kim's analysis, all-cause mortality is associated with more advanced liver disease, no surprise. But even cardiovascular disease, there's collinearity. If you have advanced fibrosis, you're much more likely to have a cardiovascular death. And this is not just from myocardial infarctions, but also from heart failure. So we took this one step further and actually took our non-cirrhotic, non-diabetic patients with NASH who have no cardiac history, and then we essentially put them on a treadmill and asked them to exercise. And this is what we found. We just showed this at ASLD. And you find that as you start scarring up your liver, your exercise capacity goes down. These are all asymptomatic, non-cirrhotic patients. Similarly, their peak metabolic VO2 goes down simultaneously. So your myocardial, this is physiologic evidence that your heart is not functioning properly, even when you're asymptomatic and you have NASH. And conversely, as you start exercising them, we did stress echoes at the same time. You find that their ventricular pressures start rising. So you can't exercise, you're unable to exercise, and your ventricle starts filling up because it's too stiff. It is unable to pump. So you have a stiff heart along with a stiff liver. So again, thinking about integrated approaches to these patients is really critical. And anyone who doesn't that is going to get left behind. So how do we find our patients then who have all these organs that are stiffening up? Well, we know as you progress from healthy to cirrhosis, you get fatty liver. We have about 86 to 100 million people with this, about 19 to 15 million people with NASH. And we've come to this concept of the high-risk NASH, which is a person who not only has NASH, but has high activity, has already started scarring up their liver. We think they are the people most likely to go to that final step where you get cirrhosis and particularly are at risk for liver failure and liver cancer. So these are the groups that are currently targeted for intervention beyond lifestyle. So our historical way of finding these patients is with the liver biopsy. But liver biopsies are, all of you, those of us who practice this know it's invasive, painful, and actually has a 1 in 1,000 risk of mortality. Now, no diagnostic test should have any risk of mortality. It's just completely unacceptable. So other than the pathologists who read the biopsies, most of the time inaccurately, nobody loves liver biopsies. And just to give you the math, if you say 60 million Americans have fatty liver disease and need to be biopsied, at the rate of 1 in 1,000 for mortality, that's 60,000 deaths from just your making your diagnosis. So this is just completely untenable. So we need better ways of finding non-invasive tools. And this leads us to what we call the biomarker endpoints and other resources, the best algorithm from the FDA. And there are 3 processes over here. There is a full-fledged independent biomarker qualification program, scientific community, and drug approval. There's some differences. Drug approval, each company develops its own biomarker to tell whether you can use it to identify who to treat and to assess whether you are responding. But your label will just say you can only use it for that particular drug. And the company carries all the risk. Scientific community consensus is another way, but it takes forever because the scientific literature is always confusing. And unfortunately, there is now a lot of attention that 90% of academic literature is not reproducible. And so that makes it very, very difficult. So the biomarker qualification program is sort of the mainstream pathway by which biomarkers are currently being developed. And the latest PDUFA Act really brings FDA into a central role working with the developer of the biomarker in this process. And so once again, we try to assess disease activity and disease stage to make predictions about where a person falls in that 4 quadrants that we talked about. And so we look for markers of metabolic perturbation with lipidomics, microbial products, markers of inflammation, cell stress, and so on and so forth. And so we have imaging tools, we have circulating tools, we have markers of quantitative liver function. There's all kinds of biomarkers out there. Unfortunately, most of the literature is pretty weak because they try to lump everything all together and try to solve all the problems of the world in every paper. I find the reviewers and the editors of the major journals primarily responsible for this, because if you send a very focused paper, they send you a 3-page diatribe of what about this, what about that, so you end up writing this nonsense paper, which gets high citations. But that doesn't get the job done. If you think about the use of biomarkers, you got to think about what you're going to do with that biomarker. That leads to the concept of a fit-for-purpose biomarker. So if you think about the disease from susceptibility, I'm just describing the previous algorithm I showed you in a different way now. Susceptibility, descriptive time progression, descriptive threshold of concern, diagnostic monitoring, pharmacodynamic, predictive, safety, response. These essentially capture this cycle from normal physiology to pathophysiology, pathology, disease, changes in, and then once you intervene, changes reversal of this whole pathway. So depending at each node, that's a specific context of use. And in order to validate a biomarker, you have to define the population for that context of use and have the appropriate endpoint that's relevant to that particular question. So there is now a major transatlantic effort to develop biomarkers. And so the Litmus Consortium is funded through the IMI, the NIMBLE through the FNIH, working very closely with the FDA and with the Liver Forum, and Veronica's going to talk about this tomorrow. But essentially, this aligns this biomarker development with the regulatory science. So we're very hopeful that in the next 4 or 5 years, we will have non-invasive tools so that we can eventually put the biopsy needle aside. Finally, what's the path to approval? Approval requires demonstration of clinically meaningful benefit, which is defined by how a person feels, functions, or survives. Now, sometimes with chronic diseases, it takes a very long time to show that something person changes in terms of survival. Feels and functions are harder to quantify, they're non-specific. So it makes it hard to say, because I gave this, the person feels better. So in those conditions, there is a pathway called Subpart H, which is based on an accelerated approval so that within a short period of time, if you can show certain changes, that is acceptable as a surrogate endpoint, but with the caveat that you're going to continue the studies to show that this short-term improvement translates into long-term clinically meaningful benefit. Or you meet what's called a generally accepted surrogate, which everybody believes represents a true change in health status. So for example, in hemoglobin A1C, a drop of 0.8 is a generally accepted surrogate. Bone density has been validated as a generally accepted surrogate for osteopenia. So similarly, for NASH, we have progression to cirrhosis is our generally accepted surrogate. So Subpart H allows us to look at short-term changes in disease activity, which is resolution of steatohepatitis or decrease in disease activity. On the other hand, for cirrhosis, you have to show either improvement in stage or reduction in MELD, and in the long term, you have to show improved survival. So coming back over here, there's a lot of activity in the field. And just this morning, very, very exciting data with a thyroxine analog showing that over 75% of patients were able to essentially defat their liver in a very early phase trial. So a lot of work going on, and as you might expect, logically so, a lot of activity at the front end, but there are drugs that are being developed along the entire pathway. And once again, the issue becomes activity versus disease stage. So in the short term, depending on your mechanism of action, you want to show change in disease activity. In the long term, you have to show changes in clinically meaningful outcome or a generally accepted surrogate, which is prevention of cirrhosis. But if you have a drug that is working at fibrosis, there's no reason to think upstream disease activity will be changed. There, even your initial readout has to be fibrosis. So activity drives stage. Stage is a marker of disease progression. In pre-cirrhotic stages, fibrosis is important, but when you think about fibrosis, the relevance depends on the mechanism by which you reduce fibrosis. If you reduce fibrosis by reducing disease activity, it's highly relevant and biologically plausible. On the other hand, if you have a primary antifibrotic drug, you still have to think about what's happening to the disease upstream, all that chemicals substrate that is coming into the liver and causing injury to the liver. So you have to figure out a strategy for that. But it positions drugs for combination therapy. And if you have both types of effects, it depends on which effect predominates. But once you get to cirrhosis, it's really fibrosis that drives clinical outcomes. From bridging fibrosis into cirrhosis, the disease activity markers, particularly histologic, don't matter. It's actually fibrosis. And so people try to look at portal hypertension, but the problem with portal hypertension is that you have to show that a decrease in hepatic venous pressure gradient with a specific mechanism of action actually improves clinical outcomes. So if you can put a TIPS in, that's the best way to reduce your portal pressure, but frequently clinical outcomes do not improve. And of course, you have to show that a decline in function in liver failure, decreased progression to MELD is currently one of the surrogates that is accepted, and of course, composite clinical outcomes. MELD is widely known, well established, related to mortality, easy to measure, everybody can do it, and so right now, the MELD threshold of 15, above which we would normally start thinking about transplant, is considered a threshold value, above which you're considered to be a quote-unquote liver death. So your take-home messages, I guess, from my topic that I was given, which is biomarkers, combination therapies, and clinical outcomes, is that NASH is a clinical syndrome driven by, that was a Freudian slip, by metabolic substrate overload to the liver. The biology of NASH has significant collinearity with the biology of heart failure with preserved ejection fraction and type 2 diabetes. Integrated approaches to non-invasive assessments that provide a readout of disease activity and stage in key end organs is needed. Therapeutics should go after nodal targets that are key for disease development and progression. Combinations should be rational and based on proper stepwise clinical development. Trial design innovations are currently underway. Veronica is going to touch on that tomorrow to allow accelerated assessment of combination therapies to improve clinical outcomes. So I'll finish here by saying, this is an old Chinese saying, superior doctors prevent disease, mediocre doctors treat it before it's evident, inferior doctors treat full-blown disease. And I think we all have lots of work to do. Finally, I'd like to acknowledge everybody who contributed to this work. Thank you.